coming to the ABI seminar. This is our first PhD access seminar by Shasha Young. And Shasha did bachelor's degree in computer engineering from Canterbury University, specializing in image processing and machine learning. And then she made a wise decision of moving off to Auckland and did a PhD at the ABI with the Justin over there. And she has a passion in computer vision, machine learning, and musculoskeletal modeling. And she mixed up in her PhD to a successful project where you're going to be watching it today. So all yours, Shasha.
Okay. Thank you, Vicky. I don't know, devices? Yeah, okay. Hi everyone, once again, I'm Shasha. It's my pleasure to talk to you today about my PhD study, 4 years in the making, population-based modelling in clinical musculoskeletal biomechanics. So, yeah, okay. First off, why population-based modelling? Well, because of technology these days and the access to online repositories such as the Physium project and Map client and cloud computing, we have access to these large collations of imaging data that is now available to us online. This allows us to create population-based models which can then be used for rapid prediction and translatable into the clinic, because these models can be used in real time. Just as a quick note for anyone that doesn't know the MAP, which is the Musculoskeletal Atlas project, and the Physium project, they're both developed at ABI. Go check it out, they're very good programs. Within the literature, there are two main types of machine learning. We have supervised and unsupervised learning. Supervised and unsupervised learning. And for supervised learning, we look at both the input and the output when developing the predictive model. Whereas with unsupervised learning, we group and interpret data based only on the input data solely. This is good for clustering type algorithms. So within supervised learning, there is a classification and regression-based model. The main difference between classification and regression is the type of data. So if you look at the image here, you can see that for regression-based models, the data is centered usually around the mean, whereas for classification, the data is more dispersed and it falls to either one or the other side of the curve in the classification curve. There are other algorithms such as deep learning or convoluted neural networks, but these algorithms are more complex. They're more useful to large data sets with multi-layered complex data structures, and we didn't use them. Within the literature, there's actually been a lot of examples of multivariate regression-based prediction models. So if we look at Valba and Smoger et al., they actually use principal component analysis of shape to predict features. However, Valba predicted the mandible joint for replacement in surgery, whereas Smoger looked at the patella shape to predict kinematics in X-ray fluoroscopy. Wu et al. used a multivariate and quadratic partial least squares method to predict nonlinear muscle mechanics from facial gestures and muscle activations. And whereas Fernandez et al. Used a linear form of partial least squares regression to predict calf muscle shape, stress, and force from muscle activation and length. Zhang et al. Predicted femoral cortex geometry from anthropometric data and femoral principal components analysis. And Van Dyke et al. Predicted pterial-femoral cartilage also using PCA modes of bone shape. So this brings me to my thesis aims, what we wanted to do. Firstly, we wanted to use a consistent data repository such as the VIFM, which is the Victorian Institute of Forensic Medicine in Victoria, Australia. We also wanted to create a semi-automated method for data input such as segmentations, and we used and create a user interface that is more understandable to clinicians. So instead of saying to a clinician, we have PCA modes of 1, 2, and 3, which may not mean a lot to them, we want to tell them, okay, this is most influenced by sacral tilt, vertebral disc spacing, and spinal size. And we also wanted to make our data and our algorithms available to the wider research and clinical community, so it's all available via plugins on the MAP client. So once again, based on the data set that we had for our studies, we used a regression-based machine learning algorithm. We adopted a principal component analysis to select the main features or characteristics of the data set, and a partial least squares regression to learn and predict outcomes. Regression methods that we use are mainly suited to smaller data sets of less than 100, whereas deep learning and convolution neural networks are more suited to larger data sets of 1,000 or more. So this brings me to the thesis structure. My thesis structure was divided into 3 main topics. Firstly, relating shape and sodium fluoride tracer markers in the lower lumbar and looking at bone degeneration. And secondly, predicting fat-free muscle volume in the lower limb. And thirdly, relating wearable sensors to net knee reaction force in patients that had undergone total knee replacement surgery. So my first study was relating spine shape to sodium fluoride PET-CT. We know that lower lumbar pain has been associated with alleviated bone metabolic activity. And this bone remodeling is actually what the sodium fluoride biomarkers bond to chemically. And so the aim of the study was to identify what specific features in a lower lumbar shape correlates to sodium fluoride uptake. We also wanted to find a way to quickly provide clinicians using a 2D X-ray whether or not someone should go for this further sodium fluoride PET-CT because it is higher radiation. So if we can avoid that, that's great. So we did this by firstly segmenting out the subject-specific geometry from the PET-CTs and using a method called freeform deformation or host mesh fitting. We morphed a generic lower lumbar to the subject-specific geometry that we got from the CT, which gave us a consistent group of nodal models across our population. We also extracted the sodium fluoride hotspots from the PET-CT and mapped them onto the patient-specific geometries. Then we used principal component analysis to characterize or extract the main features, so the main features of sodium fluoride uptake and the main features of lower lumbar spinal shape. Then we used a partial least squares regression to find a linear correlation between these 2 models. When we looked at PCA, or principal component analysis, we found that the 3 main modes of variation within our population was sacral tilt, which you can see here from how the red and blue deviate. They're the 2 extremes in our population. And vertebral disc spacing, as you can see here from whether or not the spine is compressed. And lastly, spinal size, which is a smaller mode, but you can see how the vertebrae are slightly larger. And when we when we perturbed the results by plus or minus 2 standard deviations, we found that sodium fluoride is actually most influenced by sacral tilt, followed closely by vertebral displacing. And we also used the partial least squares regression to predict the sodium fluoride uptake based on known geometries. And as you can see here, we've got 3 representatives with their predicted on the left and the actual on the right. The red and yellowish areas show the sodium fluoride uptake, and the blue is where there's no sodium fluoride. When we did an analysis to compare the sodium fluoride intensity values by node, we found that there is an accuracy of 71 plus or minus 3% in terms of predicting the sodium fluoride intensity values. Whereas when we binarized it into zeros and ones to solely look at the sodium fluoride uptake pattern or distribution, we got a higher accuracy of 85 plus or minus 3%. This basically means that our model could predict the distribution or the pattern of sodium fluoride, but with the intensity values, it usually over or under predicted. So what we learned from the study was that sacral tilt, vertebral disc spacing, and spinal size described 88.7% of our shape population. That sodium fluoride uptake was most sensitive to sacral tilt, followed by vertebral disc spacing, respectively. And that when we predicted the sodium fluoride hotspots, our prediction accuracy was 71% in terms of intensity values, and 85% if we're just looking at the qualitative pattern. And if we have patients reporting lower back pain, we can say that if they have this type of profile, so increased sacral tilt or reduced disc spacing, then they're good candidates to go for this PET-CT, sodium fluoride PET-CT, because they're likely to have bone degeneration. When looking at our study, there are a few considerations that must be mentioned. And firstly, that we can confidently report on how sodium fluoride is influenced by sacral tilt and vertebral disc spacing, and because that's what we looked at, but we can't say anything about the origins of the bone degeneration because we didn't look into the mechanics of it, because we'd need to know muscle forces and loading history, which we didn't have access to. Practical uses of the study, which is quite cool, is when we were discussing this with a clinician, he was like, okay, actually this 3D model that shows the rendering of sodium fluoride uptake is actually very useful. It's better for me to see it in a 3D model than to look at just a 2D PET-CT and see like this is roughly where the sodium fluoride should be. Our model can also, if we use finite element freeform deformation or like a projection, we can actually use the 3D models to fit a 2D X-ray to reveal potential compression and sacral tilt of a patient. So that's quite useful as well. And if we can actually, using this shape and sodium fluoride uptake data, do an FE model of the spinal disc and stress to calculate the stress, but then we'd have to make assumptions on the historical data and muscle loading, which we didn't have access to, but potentially in the future what you could do is place a sensor on somebody, ask them to wear it for a week or so before they have their scan, and you could do it that way. Okay, this brings me to my second study, which is rapidly predicting fat-free muscle volume. And so we wanted to know subject-specific muscle volume, especially the fat-free muscle volume, because this is the mass that actually does mechanical work, which we can then use for later on to calculate power in biomechanics. It also allows us to synthetically create a population of healthy muscle volumes for comparison with pathology. And we also did this because mainly MRI is quite costly. CT is not always feasible in healthy populations. And come on, everyone knows manual segmenting is very time consuming and tedious. So we did this by using machine learning on CTs from the VFM dataset once again, and to rapidly predict a person's muscle volume based on anthropometric measurements. And the way we did this is first segmenting the muscle volume from the CT data collection, as well as extracting their anthropometric measurements. So that was their height, their weight, their age, their sex, leg length, thigh girth, shank girth. And we chucked it all into a stepwise regression model, which basically evaluates the significance of each anthropometric measurement to the muscle volume. So how important one is to the another. And we used a partial least squares regression to predict the muscle volume, leave one out analysis, and then we validated the whole model on external MRI dataset. So looking at the statistical learning schemes that we used, is we've got the first one, which is partial least squares regression. The second one is a quadratic partial least squares regression. So this one's a linear one, and this one is a quadratic interpolation. And this one is a spline fit PLSR, so instead of a quadratic interpolation, you use a spline interpolation. And the second two are a support vector machine, but the first one being a linear one and the second one being a polynomial interpolation. From the graphs, you can see that the PLSR did the best in terms of both the leave one out analysis and the MRI validation. And if you look at spline, because it's spline fit, the model performed very well in terms of the leave one out analysis, but the algorithm was actually overfitting to the data, and so when it came to predicting the external MRI data set, it actually did very poorly. So what we learned from the study is that the three main important metrics or anthropometric measurements that influence muscle volume is shank girth, sex, and leg length, respectively. That in all the models that we compared, the best one was the linear partial least squares regression, and at an accuracy of 87% using a leave one out and 76% on the independent MRI data. When we looked at SVM and other higher order polynomials methods, they did not perform as well, and mainly due to overfitting again. So with the study, we felt that any validation method that we use, it should always be combined with an independent data check, so such as the MRI data check that we use for the study. This means that you can use K-folds or leave one out to train and test your data, but in terms of validation, you should always validate on a data set that is independent from your study and that your model has never seen before. This should be your gold standard if you'd like. And it's also important to note that we calculated the fat-free muscle volume, which is the mass that does mechanical work. So passive soft tissue and stuff is not important when computing muscle power in biomechanics. We originally had 23 subjects in our study, but we increased the numbers and we performed a convergence test on 20, 30, 40, and 50 people. And we found that there were no more than 1% improvement after 30 people, which is consistent with what Zhang et al. Found within the literature, where they converged after 20 to 30 subjects. So what the study actually provided was quite interesting in terms of we can, if we trained and tested on a specific muscle group, we can predict a specific muscle group, like the quads, but we focused on the total muscle volume, and we found that the most practical use for this is actually in terms of comparisons within the clinic. So instead of a clinician and looking at a chart to see what your healthy muscle volume should be, we had this model, and based on your anthropometric measurements, you can create this 3D model of what your muscle volume would look like. And then if we have someone with pathology, you can say, okay, well, this is what your muscle volume should look like, this is what your muscle volume actually looks like, and this is how much you deviate from the norm. And so you can classify the degree of pathology and use that as treatment or guiding treatment, to guide treatment. Okay. So coming to the third and final study, a population-based open sim model integrated with wearable sensors to assess total knee joint replacement patients. The overall goal for this project was to evaluate whether wearable sensors as a surrogate tool for net knee reaction force after total knee joint replacement was suitable. And we followed patients over their recovery period of approximately 6 weeks. This is a timely study because the number of wearables within the literature has increased exponentially since 2005. And for the study, we followed 10 people that had undergone a total knee joint replacement as they recovered from surgery, so approximately 6 weeks. We collected gait analysis and open sim simulations at baseline, so their initial consultation before surgery, and then once again at 6 weeks after their recovery period. At all time points, so each week in between, we collected their sense acceleration and their Oxford Knee Score questionnaire twice a week. This was to basically gauge how they were feeling along their recovery period. We did this because we wanted to answer 2 main questions. Is peak tibial acceleration during heel strike, which we've termed tibial shock, a good surrogate metric for the net knee reaction force? And is the subjective Oxford Knee Score questionnaire consistent with the objective measures from the IMU derived tibial shock, which we measure? So firstly, to test out the framework worked, we took a group of 4 healthy control people to AUT Millennium, the gait lab up there. We got them to walk at 5 different speeds over the split belt force plate. We did this so we can control for speed, unlike the knee joint replacement patients. We could also assess for repeatability on multiple trials and assess for repeatability over different sessions. But this also gave us a more clear, defined relationship between the peak tibial shock and the net knee reaction force. So like I said, we took 4 healthy controls, but I'm just going to show you 2 representatives here. We placed the sensors, 1 on each leg, on the anterior medial tibia, and this is the region that has the least amount of adipose tissue. So you can get the clearest reading of the tibial shock that's supposed to go up the tibia at heel strike. And then we got them to walk at 5 different speeds across the split belt force plate. So this is the first female control. Well, we've got the accelerations in G's on the X and the net knee reaction force on the Y in body weight. Here we've got session 1 in red dashed and session 2 in blue solid, with the standard deviations in the respective colours. So from this we found that there was a clear linear relationship between peak tibial acceleration and net knee reaction force. That the average errors of acceleration across our 4 people was 3.75 for acceleration and 8.5 for force. This basically tells us the minimum error that we can expect when using the same pipeline for our total knee replacement patients. this is the controlled male with the same accelerations in G on the X, net knee reaction force in body weight on the Y, session 1 in red dash, and session 2 on blue solid with the standard deviations and the respective colours. When we compared between in each person's session, we found that there was only an increase in error of 1% for acceleration and 0.3% for the force. This basically provides us with the confidence in the repeatability of our method and taking this forward to the total knee replacement patients. It's also important to note that the IMU sensors that we used for the study are actually automatically synchronized to the motion capture within the Nexus software. So if you look here on the graph, the red circle here is the peak tibial acceleration, which is characterized by the peak acceleration just before the deceleration. The graph is inverted just for anyone. And that correlates or corresponds to the ground reaction force at heel strike, which is characterized by usually a little notch before the two humps. And we used the map client to create subject-specifically scaled open sim models, which we used for calculation of the net knee reaction force. And the way this worked is that the map client took a population of meshes from the VFM dataset, and it scales a open sims model based on subject-specific parameters, so height and weight, age and sex, but it also constrains it to physical anatomical conditions. So you won't get any scaled models that don't look really anatomically incorrect. And it's important to note that our net knee reaction force is from inverse dynamics from OpenSim, and that we didn't compute the total contact force, which includes muscles and ligament forces. And mainly because we didn't have ethics to measure EMG on, and so we couldn't validate muscle forces. And because we're doing this on total knee replacement patients, their muscle moment arms is very different to the generic model within the OpenSim. So you can't use that as a model because it'd be completely different and the moment arms would be changed. Yeah, so using the same pipeline, we processed 10 patients that had undergone total knee replacement. We placed the sensor on both legs on the anterior medial tibia in the same spot, but we got them to walk over the force plate at their own self-selected speed. We collected their tibial accelerations, which we matched up to their ground reaction force, and we also placed the sensors on them twice a week over their recovery period to get the average peak tibial acceleration. So we used OpenSim to calculate their net knee reaction force. We extracted the net knee reaction force at heel strike and correlated that to the acceleration and the gait to give us a linear relationship between the accelerations in G and the net knee reaction force in body weight before and after surgery. So before in red, pre, and after in blue, solid, post. And to predict an individual's net knee reaction force, so what we did is we assumed a linear interpolation between the pre and post, and we used that relationship and we used their known average peak tibial acceleration from the sensors that we measured to predict their net knee reaction force over that recovery period. What we found from the study, now we know that a linear interpolation is not actually what happens, but because we only had 2 time points and a linear interpolation was all that we could expect, ideally we'd have multiple time points and we'd assume that the relationship is more similar to, in their recovery, to the acceleration. And from the results, we found that there were 3 main groups of people within our population. And the blue, that remained consistent in their predicted net knee reaction force over the recovery period. The red, that increased over time, and the green, that decreased over time. And the green are the people that the clinicians are most interested in. These are the people that are at risk of revision surgery. So we want to help them improve in a way that could get them back up to either similar to the blue group or the red group. We also looked at their Oxford knee scores, and on average everybody reported to be improving across time, and most people's Oxford knee score had these 2 characteristic dips at session 2 and session 12. And when we compared their Oxford knee score in rustic brown to their IMU accelerations in cornflower blue, we found that some of their relationships are quite consistent in their reportings, but others, and most of the people, actually deviated from what they reported. So what we learned from the study, sorry, I'm slightly sick, my voice keeps giving in and out. What we learned from the study was that there was a linear relationship between tibial shock and net knee reaction force at heel strike, that the linear relationship is very subject specific, even though we normalized for body weight, and that, that this relationship is velocity dependent. And what's very important or interesting to note is that the Oxford knee score, which most people report as improving, is not actually consistent with what we found from the IMU activity levels. So in terms of the considerations of this project, we know that we only had 2 visits to the gait lab. Ideally, we'd have more time points over that recovery period. And if we wanted to make this practical within the clinic, we could use a portable force plate to do a weekly calibration of the sensors to the force, and that would be ideal. Well, but based on the ethics that we had for the project, we only got 2 time points. In terms of some of the graphs, we found that some people had quite narrow accelerations, but some people had quite broad accelerations. And this is mainly due to people walking over the force plate. Some people were quite consistent in terms of their walking, but some people deviated or had a large variation. And this could be due to anything for like starting to feel pain. And so maybe at the first trial, everybody was like, great, I can walk like this, and they hit the they hit the force plate at a certain speed. But when it comes to maybe the 3rd trial, they're a bit more tired and their knee is starting to hurt, so they sort of like shift the way that they walk or change their gait style to offset the affected leg, and usually they would walk slower. So you get this variation of speed over the trials. So practical uses for this study was that we actually found that the sensor activity reveals the reliability of the Oxford knee score. The Oxford knee score is used quite wildly, like a lot of places use it, and it's been shown in other studies as well that it's not always the best metric to use. These sensors can also help clinicians remotely identify patients that are in need of attention, and it can improve the management of patients in different health boards. So what I mean by that is within the Auckland region, patients that have gone for knee surgery have to go to physio for a certain amount of time after their surgery. Whereas in Christchurch, they're only seen twice over that 6 weeks and they don't have to go to physio at all. So one way the sensors could be used is to optimize the number of patients who need to be seen physically, because you could do this remote assessment of how they're improving over time. So currently the sensors are linked via Bluetooth to an app on a smartphone. Ideally in the future we want to link this out to the cloud computing, and this is actually currently being done right now. This will allow clinicians to actively monitor how their patients are recovering and whether or not they should come in, find out what's going on, why you're not recovering, are you following our recommendations or not. Because the overall end goal is you want to avoid revision surgery because it's timely, it's costly, and it's painful. So overall, the insights from this thesis of population-based modelling is that we can inform clinicians in real time if candidates are suitable for costly imaging, such as the first study of sodium fluoride PET-CT. It also provides us a way to rapidly make predictions that might be too expensive to measure, such as the second study of muscle volume. And it allows us to embed real-time predictive algorithms on wearables. And the study originally was designed to be a population-based study with a regression model to correlate sensor acceleration to net knee reaction force. However, because of the high dropout rate, we didn't actually get the numbers that we're hoping to. And so we're currently recruiting more people for the study to use a population-based statistical model on that, which will then be embedded on the software. But the overall and end-all message from population-based modelling is that it is there to aid clinical decision-making. It is not to provide a complete confidence to replace clinicians. We're not saying that. That will never be the case. It's just to help further someone's historical data. I'd like to thank, before I wrap up, I'd like to thank MedTech Corps for funding this project, AUT Millennium for their GATE lab, and IMSU for their sensors. And just to note that as an extension work of my PhD, we're currently looking at computing the total net knee joint reaction force, which includes muscle volume. This gives us, this will allow us to see if the relationship of peak RMU tibial acceleration will hold true to the net knee reaction force, like the total knee joint contact force. And we're also implementing the wearable sensors on a larger scale study. So we're including both the Auckland and Waikato hospitals to get larger numbers and implement population-based modelling to embed on the sensors in real time. Thank you.
Any questions from the floor? Yep.
First of all, thank you very much for the great talk. I have two basic questions actually regarding the machine learning algorithm you've used in the second study. You mentioned you use regression methods. You mentioned regression accuracy. But if I'm wrong, but is that is accuracy a defined form for classification? So did you use R squared score for that?
Yes, we looked at both the R squared and the root mean square of the error.
And the other thing is, you use PCA before you introduce your model to square regression. So for PCA, as far as I know, is that the idea of PCA is for dimensionality reduction and also for feature extraction. So if you reduce the dimensionality of your data set to a certain level before you use it for your linear regression, then how could you compare that to a higher dimensionality regression tool such as polynomial support vector machines?
Well,
to
actually,
justify this comparison?
uh,
Is it possible, for example, for you to compare it against other linear regression methods?
well, actually, PLSR or partially squares regression has PCA inherently in it. If you look at the methodology of how partially squares actually breaks down the composition matrix, it's the same way in PCA. So PCA is actually like the first step of PLSR. And like, sorry, what was your question?
My question was, if you're reducing the dimensionality of your data by using partial least square regression, which is the PCA, then how would you compare that against a higher dimensionality regression tool such as polynomial support vector regression?
Well, you look at the R squared, but you also look at how well it predicts in terms of the external data. So that's why we validated on the MRI data set. Because as we use, so when you train the model using PLSR and then you predict it, and you get an accuracy value for the MRI data set, and you do the same with the SVM, you get SVM, you train it on the VFM data set, and then you predict the MRI. Isn't that a comparison?
Thank you.
Sorry?
Thank you.
Okay.
Your PhD was quite unique in that you have 3 different projects within one PhD. So was there any difficulties doing all those 3 kind of related but different projects within that 4-year period, which is amazing. Then you finished all 3 in time.
It was quite fun. I liked it. Yeah.
So, yeah. So among your knee replacement, so dropout rate was quite big, was it?
Yeah. For the ethics, we originally put 100 people. But then we only managed to get 10. It's just that we recruited quite a lot. We recruited around about like 50 to 60 people, but the dropout rate is quite high because you're not only getting people to go out to the gait lab before surgery and after surgery, you're also wanting to follow them for a whole 6-week period.
But then you did only twice during the 6-week period? Is that what you said?
Yeah, for the gait lab, it's twice, one before surgery and one after.
After 6 weeks.
After 6 weeks. But then you're also meeting them every week for twice a week at their physio sessions to put the sensors on. And they actually walk home with the sensors for like 8 hours and then take it off when they sleep.
Yeah. So how many more do you need to be able to predict from your wearable sensors out of the knee joint? You have 10 at the moment.
Yeah.
How many more do you need to be able to make that prediction?
Well, with the study, the extended stuff that we're doing now with Tor and Paul, we're hoping to get 50 of the total knees and 50 of the uni knees. Wow. Yeah, but I don't know. I'm hoping that if we have a convergence rate of 20 to 30 and Ju has the convergence rate of 20 to 30, that maybe 20 to 30 could work.
Okay.
Okay.
So you have recruited 50
No,
already?
we're planning to. At Green Lane and Waikato.
Wow. Okay. Hope that's going to work. Any other questions for Shasha?
In the middle of the 3 studies, if I understood correctly, the fat-free mass was related to the height of the individual or the length of one of the long bones.
The long bones.
So related to height, wasn't it?
Yeah, so one of the anthropometric measurements that we looked at for the model was height, and Jeff can talk about height much better. He did the study with height and weight, right? Yeah. Yeah. But what we found quite differently was that we found that if because we're looking at the fat-free muscle mass, shank girth was a better predictor for it, just because most people don't tend to have really fatty girth of their shank.
So if you don't have fat on the shank?
No, you do, but you tend to have less. Most people have fat around like the middle and thigh butt region. Yeah.
Missing something there, but that's fine.
No, please, maybe you could rephrase your question? I'm probably not getting it, sorry.
We still have the fact that the fat-free mass was related, I'm not sure whether positively or negatively, to the individual's height, correct?
We found that it was correlated to shank girth, age, shank girth, sex, and leg length. So I guess leg length would be a variable of height, because we're looking at just the lower limb. So instead of taking the height of the whole individual, we just take the length of the lower limb, which is the area that we're measuring or predicting. So yes, there is a relationship there.
So long-legged people have less fat and more, or a lower fat to muscle mass ratio. Yes or no?
They tend to, yes.
And do you have some insight into why that is the case?
No, we didn't look at that. But that could be like a lot of factors. There's like a fat depository in the body can be like genetics. It can be like chemicals if you're taking medication. So it could be a very like wide range of things.
Okay.
Dennis, I think you've also got to look at the fact that the data set that the model was trained on, so the model can only predict as well as the data that it's seen. So the data that she got was from a particular population of the IFM. And if you get people who are kind of real outsiders to this, a model wouldn't be able to predict them very well. So people who are extremely obese or people who are high performance athletes may fall out of this prediction ability.
Mm.
So we're just looking at, I suppose, a little more, and she trained it on quite a broad set that will get pretty, and I guess the independent MRI validation
Fine.
If I may add something to this discussion, not to continue to muddy the waters, but so another way of thinking about the fat-free muscle mass is just it's the lean mass, right? The lean muscle mass of the body, and so it's a positive correlation between leg length and the lean muscle mass. So people that are taller have more lean muscle mass by virtue of having more space in their body to fill with muscle, as well as being taller and needing more muscle to move that taller frame. So you've got leg length is a positive predictor, gender is a binary predictor, and then the shank girth is, as Shasha was saying, you don't tend to develop a whole lot of adipose tissue around the calf compared to a lot of the rest of the body.
Sure.
So that's sort of the most faithful predictor of the lower limb muscle, lean mass. That's Shasha's model, which is distinct from the one that I did, which is more of a normative predictor of how much muscle you should have, mechanically speaking, which is based on mass and height. If you have more mass or more height, you need more muscle to move that body. Where Shasha's is not normative but positive, saying the person could be sedentary, could be cachexic, could have any number of pathologies.
Oh, no, we didn't
when
do
you see a decline in the muscle mass, that'll be reflected in the decline in the shank girth. I don't know if that makes more or less sense than where we were at previously.
Somewhere between more and less.
Great.
Any other questions? If not, let's thank Shasha for giving us.